Hello and welcome to the Palmetto GBA Pulmonary Rehab webcast. My name is Lynn Kelly. I'm a Senior Provider Outreach Education Consultant. I'm also a registered nurse. Thank y'all for attending today, and we'll get started here. All right, we're going to start off with an overview. As you know, pulmonary rehab is a multidisciplinary program of care for patients with chronic respiratory impairment who are symptomatic and often have decreased daily life activities. Benefits of pulmonary rehab are decrease the symptoms of your disease or condition, ability to function better in your daily life, increased ability to exercise, decreased symptoms, and better management of anxiety and depression. Chronic obstructive pulmonary disease is defined by the World Health Organization lung disease characterized by chronic obstructive of the lung airflow that interferes with normal breathing and is not fully reversible. COPD is a lung disease that makes it hard to breathe. It is caused by damage to the lungs over many years. Key indicators for considering a diagnosis of COPD, dyspnea that is progressive, characteristically worse with exercise, persistent, a chronic cough, and chronic sputum production. Assessment goals: you want to determine the severity of the disease, its impact on the patient's health status, and the risk of future events, for example, exacerbations, to guide therapy. Consider the following aspects of the disease separately: current level of patient symptoms, severity of the spirometric abnormality, frequency of exacerbations, and presence of comorbidities. The characteristic symptoms of COPD are chronic and progressive dyspnea, cough, and sputum production that can be variable from day to day. Dyspnea, progressive, persistent, and characteristically worse with exercise. Chronic cough, may be intermittent and may be unproductive. Chronic sputum production, COPD patients commonly cough up sputum. The GOLD classifications are the main method doctors use to describe the severity of COPD. GOLD is short for Global Initiative for Chronic Obstructive Lung Disease, a collaboration between the National Institutes of Health and the World Health Organization. The GOLD staging system classifies people with COPD based on their degree of airflow limitation. The airflow limitation is measured during pulmonary function tests. When blowing out forcefully, people with normal lungs can exhale most of the air in their lungs in 1 second. The volume in 1 second forced exhalation is called the forced expiratory volume in 1 second, or FEV1, measured in liters. The total exhaled breath is called the forced vital capacity, or FVC, also measured in liters. In people with normal lung function, the FEV1 is at least 70% of the FVC. An FEV1 less than 70% of FVC can make the diagnosis of COPD in someone with compatible symptoms and history. This chart represents the GOLD classifications from stage 1, mild COPD, through stage 4, very severe COPD. The test results should be in the chart and should be an official report. Physician ordering pulmonary rehab or writing the pulmonary rehab orders should make note of the test and interpret the result that objectively shows the patient has moderate or severe COPD according to the GOLD standard. A pulmonary rehab program is typically a physician-supervised, multidisciplinary program individually tailored and designed to optimize physical and social performance and autonomy of care for the patients with chronic respiratory impairment. The main goal of a pulmonary rehab program is to empower the individual's ability to exercise independently. Exercise is combined with other training and support mechanisms to encourage long-term adherence to the treatment plan. The pulmonary rehab program is individually tailored and designed to optimize physical and social performance and autonomy. Effective January 1st of 2010, Medicare Improvements for Patients and Providers Act, MIPPA, provisions added a physician-supervised comprehensive pulmonary rehab program for patients with moderate to severe COPD. Medicare will pay for up to 2 one-hour sessions per day for up to 36 lifetime sessions, in some cases up to 72 lifetime sessions of the pulmonary rehab program. As specified in 42 CFR 410.47, Medicare covers pulmonary rehab items and services for patients with moderate to severe chronic obstructive pulmonary disease, as defined by the GOLD classifications 2, 3, and 4, when referred by a physician treating the chronic respiratory disease. The pulmonary rehab program must include the following mandatory components. It must have a physician-prescribed exercise, it must have education or training, a psychosocial assessment, an outcomes assessment, and an individualized treatment plan. In physician-prescribed exercise, this physical activity includes techniques such as exercise conditioning, breathing, retraining, and step and strengthening exercises. Some aerobic exercise must be included in each pulmonary rehab session. Orders. If the intervention is done on more than one occasion, the physician must order it. A new order doesn't have to be written for every day. An order can encompass several days. The order must specify exactly what is to be given and cannot be in ranges. An order can be changed. An order can be verbal, but it must be signed by the ordering practitioner. The sooner the better. Changes in orders should generally be reflected in progress notes. Aerobic exercise. High and low intensity exercise is recommended, as well as a combination of endurance and strength training at least twice a week. Education or training. This should be closely and clearly related to the individual's care and treatment and tailored to the individual's needs, including information on respiratory problem management and, if appropriate, brief smoking cessation counseling. Any education or training must assist in achievement of individual goals toward independence and activities of daily living, adaptation to limitations, and improved quality of life. Psychosocial assessment. The assessment means a written evaluation of an individual's mental and emotional functioning as it relates to the individual's rehabilitation or respiratory condition. It should include an assessment of those aspects of the individual's family and home situation that affects the individual's rehabilitation treatment and a psychological evaluation of the individual's response to and rate of progress under the treatment plan. Periodic reevaluations are necessary to ensure the individual's psychosocial needs are being met. Outcomes assessment. These should include beginning and end evaluations based on patient-centered outcomes, which are conducted by the physician at the start and end of the program, and objective clinical measures of the effectiveness of the pulmonary rehab program for the individual patient, including exercise performance and self-reported measures of shortness of breath and behavior. The assessment should include clinical measures such as 6-minute walk, weight, exercise performance, self-reported dyspnea, behavioral measures, supplemental oxygen use, smoking status, and a quality of life assessment. An individualized treatment plan describing the individual's diagnosis and detailing how components are utilized for each patient. The plan must be established, reviewed, and signed by a physician every 30 days. The plan may initially be developed by the referring physician or the pulmonary rehab physician. If the plan is developed by the referring physician who is not the pulmonary rehab physician, the pulmonary rehab physician must also review and sign the plan prior to implementation of the pulmonary rehab program. It is expected that the supervising physician would have initial direct contact with the individual prior to the subsequent treatment by ancillary personnel, and also have at least one direct contact in each 30-day period. Individualized treatment plan. The plan must have written specificity with regards to the type, amount, frequency, and duration of the pulmonary rehab items and services furnished to the individual, and specify the appropriate mix of services for the patient's needs. It must include measurable and expected outcomes and estimated timetables to achieve these goals. Written plan established, reviewed, and signed by a physician every 30 days that describes all of the following: the diagnosis, the type, amount, frequency, and duration of the items and services under the plan, the goals set for the individual. Pulmonary rehab items and services must be furnished in a physician's office or a hospital outpatient setting. The setting must have the necessary cardiopulmonary, emergency, diagnostic, and therapeutic life-saving equipment. All settings must have a physician immediately available and accessible for medical consultations and emergencies at all times that the pulmonary rehab items and services are being furnished under the program. Physician standards. Physician is responsible and accountable for the pulmonary rehabilitation program, including oversight of the pulmonary rehab staff, is involved substantially in consultation with staff in directing the progress of the individual in the program, including direct patient contact related to the periodic review of his or her treatment plan. Has expertise in the management of individuals with respiratory pathophysiology and cardiopulmonary training. Has license to practice medicine in the state in which the pulmonary rehabilitation program is offered. Direct supervision means the physician must be present in the office suite and immediately available to furnish assistance and direction throughout the performance of the procedure. For pulmonary rehab, direct supervision must be furnished by a doctor of medicine or osteopathy. Documentation. Progress notes. A physician admitting note stating the diagnosis and problems of the individual, outlining the plan of treatment, the modalities to be used, and the goals of the therapy. Evidence in the record that a physician directed care, notation in the record of supervision of each session. Coding requirements. G0424, pulmonary rehabilitation including exercise, includes monitoring per hour per session. Maximum of 2 one-hour sessions per day. Sessions during treatment must be at least 31 minutes. 2 sessions of pulmonary rehabilitation services may only be reported in the same day if the duration of the treatment is at least 91 minutes. Claims processing. Medicare contractors will pay claims for HCPCS code G0424 only when services are provided in the following places of services. 11, which is a physician's office, or 22, which is a hospital outpatient. Medicare will deny claims for HCPCS code G0424 performed in any other than and billed without place of service 11 or 22. Completion of prepayment service-specific targeted medical review of outpatient pulmonary rehab, HCPCS G0424, in North Carolina, South Carolina, and Virginia, West Virginia. Palmetto GBA performed service-specific prepayment complex reviews on claims for HCPCS code G0424, outpatient pulmonary rehab in North Carolina, South Carolina, Virginia, and West Virginia for the period of February 2014 through April of 2014. The results of the service-specific targeted medical review for all states are presented here. For North Carolina, a total of 342 claims were reviewed, with 287 of the claims either completely or partially denied. The total dollars reviewed was $359,466.35, out of which $273,146.51 were denied, resulting in a charge denial rate of 76%. This is a chart of the top denial reasons. I'm not going to read through all these, but you can see the percentages over to the left of how these were broken down. The next 4 slides are going over granular error findings. It's just a more specified definition of the denial reason. You also see how often those denials occurred. Hopefully this will give you a little more clarification as to each of the denial codes. Again, these are granular error findings based on the denial codes. In South Carolina, a total of 109 claims were reviewed, with 94 of the claims either completely or partially denied. The total dollars reviewed was $103,622.73, out of which $86,595.96 were declined, resulting in a charge denial rate of 83.6%. This table describes the percentage of the denials by the denial code. And these next 4 slides also go through the granular denial reasons based on the denial code and the number of occurrences per denial code. In Virginia and West Virginia, a total of 377 claims were reviewed, with 292 of the claims either completely or partially denied. The total dollars reviewed was $389,354.78, out of which $294,562.07 were denied, resulting in a charge denial rate of 75.7%. Here again are the top denial reasons. And again, the next 4 slides are involving the granular denial reasons for each denial code and the frequency of occurrences. Denial reasons and prevention recommendations. For reason code 5D902 or 5H902, documentation did not include required components. Reason for the denial: this claim was fully denied because the following components of the pulmonary rehab program were not submitted in the medical record. Physician prescribed exercise, education or training, psychosocial assessment, outcomes assessment, and individualized treatment plan. How to avoid this denial: submit the program component requirements when responding to the ADR request. For more information, refer to CMS Internet-Only Manuals, Publication 100-04, Medicare Claims Processing Manual, Chapter 32, Section 140.4. Change Request 6823 and CMS Medicare Learning Network MLN Matters Article MM6823, Pulmonary Rehab Services. Denial code 5D901 or 5H901, Pulmonary Rehab not warranted for diagnosis. Reason for denial: the claim was fully denied because the condition required for coverage of pulmonary rehabilitation services was not submitted in the medical record. CMS Manual System, Publication 100.04, Medicare Claims Processing Manual, Chapter 32, Section 140.4 states, as specified in 42 CFR 410.47, Medicare covers pulmonary rehabilitation items and services for patients with moderate to severe COPD, defined as Gold Classification 2, 3, and 4, when referred by the physician treating the chronic respiratory disease. To avoid this denial, submit the information required for coverage when responding to the ADR request. For more information, refer to CMS Internet Manuals, Publication 100-04, Medicare Claims Processing Manual, Chapter 32, Section 140.4. Denial Code 5D169 or 5H169, services not documented. Reason for denial: this claim was partially or fully denied because the provider billed services items not documented in the medical record submitted. To avoid this denial, submit all documentation related to the services billed. Ensure that results submitted are for the date of service billed, the correct beneficiary, and the specific service billed. Again, for more information, refer to Code of Federal Regulations 42 CFR Sections 410.32 and 424.5. The article below can be located on the Palmetto GBA website, and of course that's palmettogba.com, using the search feature. Responding to an outpatient therapy additional development request. Denial Code 5D404 or 5H404, no orders, referrals for pulmonary rehabilitative services. Reason for this denial: the services billed were not covered due to no physician's order or referral for pulmonary rehab services. In order to avoid unnecessary denials for this reason, the provider should ensure that the physician's orders/referrals cover the services to be billed prior to billing Medicare. When responding to an ADR or additional documentation request, ensure that all orders or referrals for services billed are included with the medical records. The Medicare program requires that the physician order or referral is set up for furnishing services. Again, for more information on the Medicare coverage issue, references include, but are not limited to, these resources. You have 42 CFR 410.47, Pulmonary Rehab Program, Conditions for Coverage, Medicare Claims Processing Manual, Chapter 32, Billing Requirements for Special Services. Denial Code 5D903 or 5H903, physician must be readily available. Reason for this denial: the claim was denied because the requirement for pulmonary rehab services regarding the program must be under the direct supervision of a physician was not met. To avoid this denial, provide documentation that the physician is present in the facility and immediately available to furnish assistance and direction throughout the performance of the procedure. For more information on this, look at CMS Internet-Only Manuals, Publication 100-4, Medicare Claims Processing Manual, Chapter 32, Section 140.4, Code of Federal Regulations, 42 CFR, Section 410.32, 56900, Auto Denial, Requested Medical Records Not Submitted. Reason for denial: the services billed were not covered because the claim was not submitted or not submitted timely in response to an additional development request, an ADR. When an ADR is generated, the provider has 30 days from the date the ADR was generated to respond with medical records. In accordance with CMS instructions, if the documentation needed to make a medical review determination is not received within 45 days from the date of the documentation request, Palmetto GBA will make a medical review determination based on available documentation. If the claim is denied, payment will be denied or an overpayment will be collected. To avoid this denial, be aware of the ADR date and the need to submit medical records within 30 days of the ADR date. Submit the medical records as soon as the ADR is received. Monitor the status of your claim in the Direct Data Entry or DDE and begin gathering the medical records as soon as the claim goes to the location of SB 6001. Return the medical records to the address on the ADR. Be sure to include the appropriate mail code or station number. This ensures that your responses are promptly routed to the medical review department. Gather all the information needed for the claim and submit it all at one time. Attach a copy of the ADR request to each individual claim. If responding to multiple ADRs, separate each response and attach a copy of the ADR to each individual set of medical records. Make sure each set of medical records is bound securely with one staple in the upper left corner or a rubber band to ensure that no documentation is detached or lost. Do not use paper clips. Do not mail packages COD. We cannot accept them. For more information, refer to the following articles on Palmetto GBA website at palmettogba.com. For more information, refer to the following articles on Palmetto GBA J11 Part A website, Medical Review Progressive Action Plan process. The next steps. The service-specific targeted medical review edits for Part A Outpatient Pulmonary Rehab HCPCS code G0424 will be continued in North Carolina, South Carolina, Virginia, and West Virginia. This service has been identified as a major risk area for J11, and the review results show a high charge denial rate and high severity impact errors in each state. If significant billing aberrancies are identified, provider-specific review may be initiated. Questions regarding the medical review can be directed to Provider Contact Center at 866-696-0705. KX modifier. Contractors shall accept the inclusion of the KX modifier on the claim lines as an attestation by the provider of the service that documentation is on file verifying that further treatment beyond the 36 sessions is medically necessary up to a total of 72 sessions for that beneficiary. Claims processing. Medicare contractors will deny claims for HCPCS code G0424 when submitted for more than 72 sessions, even where the KX modifier is present. For institutional claims, the type of bill is 13X or 85X and revenue code 0948. Daily frequency edits. Claims that exceed 2 units on a date of service will be denied. The next few slides are a list of examples. Example 1, patient received 20 minutes of pulmonary rehab services in a day. No pulmonary rehab sessions may be reported because less than 31 minutes of service were furnished. Example 2, patient received 20 minutes of pulmonary rehab services in the morning. They received 35 minutes of pulmonary rehab services in the afternoon. You'll report 1 session of pulmonary rehab services under 1 unit of HCPCS G code for the total duration of 55 minutes of pulmonary rehab services on that day. Example 3, patient receives 70 minutes of pulmonary rehab services in the morning, receives 25 minutes of pulmonary rehab services in the afternoon of a single day. Report 2 sessions of pulmonary rehab services under the HCPCS G code because the total duration of pulmonary rehab services on that day of 95 minutes exceeds the 90 minutes. Example 4, patient receives 70 minutes of pulmonary rehab services in the morning, receives 85 minutes of pulmonary rehab services in the afternoon of a single day. Report 2 sessions of pulmonary rehab services under HCPCS G-code for the total duration of the pulmonary rehab services of 155 minutes. A maximum of 2 sessions per day may be reported regardless of the total duration of pulmonary rehab services. References: 42 CFR 410.47, CMS Manual System Publication 100-04, Medicare Claims Processing Manual, Chapter 32, Section 140. This concludes our pulmonary rehab webcast for today. If you have questions, feel free to contact our Provider Contact Center at 866-696-0705. Thank you and have a great day.